So we're going to talk about the heart. We're going to need to talk about the surface features, the chambers themselves, and the internal features, and then the vessels and nerves actually supplying the heart, as well as the vessels entering and exiting the heart. Let's start with a general overview of the chambers, the vessels entering and exiting each chambers, as well as the valves that you can associate with each of those. And while doing that, we can discuss how blood would normally flow through those. You can see that we have 4 chambers, 2 atria, 2 ventricles. Here's your right atria, left atrium, right ventricle, and left ventricle. And so when tilted up so that the apex is inferior and the base is superior, you can see all 4 chambers. But in reality, that's not how we see the heart in situ. It's more of a posterior to anterior approach. And so you're going to see that those atria are actually located posterior to the ventricles, more than a superior-inferior organization. If we take a closer look at each atria, you'll see a small appendage hanging off each. They're known as auricles or atrial appendages. Auricle because they are ear-like, almost like a Scotty dog is what they're often referred to. And so they're the small, tiny muscular appendages that on the inside are going to have a rough surface because they're part of the original atria. There's valves separating the atria from the ventricles in this endocardial cushion, or AV valves. And it's going to be a flow through those that allows them to enter the ventricle. So let's look at the blood flow here. First, we have to get deoxygenated blood back to the right ventricle. We do that through a number of ways. The coronary veins, which is going to return the actual deoxygenated blood the heart used, come into the right atrium through the coronary sinus posteriorly. We'll look at that when we discuss the coronary vessels. But you have some larger ones you're probably more familiar with. You have the superior vena cava that's coming in superiorly to grab the brachiocephalics from the right and the left. And then you have the inferior vena cava that's going to come into the inferior portion here, the diaphragmatic surface more so, after it comes through the liver and up through the diaphragm to bring blood into the right atrium from the lower half of the body. So all that deoxygenated blood will then pass through this valve here. So the AV valve on the right is going to be our tricuspid valve because it has 3 cusps, just as the name would make you guess. And then it enters the ventricle here. When the blood enters the ventricle by passing through this open AV valve and its associated cusp, it hits the conical tapering end of the ventricle and makes a U-turn. And so you see the arrow here showing you that the blood is going to make a U-turn to go back up through this pulmonary trunk. And so this is our pulmonary trunk that's going to give us the pulmonary arteries, both right and left, that will go to be distributed to each lung. From the lungs, we're going to re-enter the heart through the left atrium by way of the pulmonary veins. So now we have oxygenated blood coming back in through these pulmonary veins. You may recall from embryo that we have that one vein that divides into 4 and is kind of absorbed into the back of the left atrium. Because that is such a different process with a lot of splitting and fusion, it can be a variable number of veins that you're going to see, but look for 4, entering more on the posterior surface of the left atrium. And then from the left atrium, we're going to enter the AV valve here, known as the bicuspid or mitral valve, because there are 2 cusps. And again, you're going to see as it enters the ventricle, we're going to do that same U-turn with the blood. It's going to come down, hit the conical process here at the end of the chamber, and U-turn up towards the aorta. And you can see the aorta trunk is actually kind of hidden behind the pulmonary trunk. You can't really see it well. And so the pulmonary trunk would be here and the aorta here. And so the aorta comes up, dives behind the pulmonary trunk coming out of the right ventricle, and then makes the arch that's going to arch back and to the left. And you'll see the arch is really how we're going to get all of our systemic blood supply to the rest of the body. But it's also going to be the aorta that supplies the heart with the coronary vessels. The small portion here, just as we exit the left ventricle, is the ascending aorta, and that's where our coronary arteries are going to be located. So the ascending aorta, the arch of the aorta, and you'll even come to see the descending thoracic aorta are vital to blood supply for the thoracic cavity. Let's now look a little bit closer at the specific features of the surface of the heart as well as the internal chambers.
So let's look quickly just one more time at the root of the lung and help us understand why the structures are in the order they are. With the bronchial tree element most posteriorly, the pulmonary artery more superior, and the pulmonary veins more inferior. So we look at the organization as they come from the heart into the lung. You can see the pulmonary trunk and associated pulmonary arteries in blue. So you see the pulmonary artery is very superior, and it's overarching those pulmonary veins as they come back into the left atrium here. So it makes sense why you would find the pulmonary artery superior to the pulmonary vein in red at the root of the lung, since that's the same organization as the great vessels.
Looked at surfaces of the heart. You have an anterior surface where the sternum would be located. You have the diaphragmatic surface where we have the fusion with the central tendon of the diaphragm. And then you have the right and the left pulmonary surfaces. When you look at this heart, again, you see that tilted nature. And so this image will help you understand that the apex is essentially opposite from the base of the heart. So the base of the heart is where most of the great vessels are going to be setting, right in the most posterior aspect, right on the bifurcation of the trachea and the esophagus.
This anterior view here, you can see the apex. The one that actually can be a little more confusing is the base of the heart. It's actually immediately opposite of the apex that we saw coming here. When we follow back, we're immediately opposite here at the base. Notice the atria, the two chambers that receive blood for the heart, are really making up most of the base, specifically the left atrium here. Here you see the anterior surface that would be intimate with the sternum, and then a right and left pleural surface on each side that will be intimate with the lung and the mediastinal parietal pleura, and the diaphragmatic surface that is going to be intimate with the diaphragmatic parietal pleura and the diaphragm. And where you have the pericardium making sharp curves here to cover it, you see the borders. And so we're going to have borders of the heart and the pericardial sac that you're actually going to be able to see in imaging. So you can see the right border of the heart here, encompassing some of the atrium and the ventricle. The left border doing the same on the left side. And then you have a superior and an inferior border. You can see that this is where our diaphragmatic and anterior surfaces are meeting up at our inferior border, for example.
So we've opened up the right atrium. We've done a nice little slice here to show some of the internal features. And some of these internal features will actually also relate to external features. We'll start here with the rough surface. So that auricle, that ear-like projection, it is all rough, made out of pectinate muscles. But there is also a small portion of the atrial wall on the right that has pectinate muscles as well. You will only find pectinate muscles in the atria. The pectinate muscles go all the way up and meet this ridge of tissue here. This ridge of tissue is the crista terminalis, so it's the terminating crown. This is the crown where the ridged muscles, the pectinate muscles, meet the smooth wall of the right atrium. So when you see this ridge, you should see smooth wall on the inferior aspect, really more the posterior aspect,
and then this roughed wall here that's seen reflecting off the anterior wall. If you follow the crista terminalis medially where it ends, you'll find the SA nodal tissue right at the area where it intersects with the superior vena cava. So you're not going to see a nice little bulge or anything that makes it visibly a node, but you need to be aware that this is the area the node would be located. So when we look at the vascular supply, you can understand which vessels, if compromised, could affect the pacemaker of the heart. So this SA node is right here by the interatrial septum. And so you can imagine that the intraatrial septum would be located here in this area just inferior. This area was indicating a valve of the inferior vena cava. So this was present in utero to help shunt blood towards a small little opening known as the fossa ovalis. Now, it was the foramen ovalis when it was patent meaning open. And now that it's simply a depression that you can't pass through, it's known as fossa ovalis. So this acted as a shunt. It allowed us to bypass our lungs while they were still developing in utero. And we were getting oxygen from our mother's placenta, so we had no reason to oxygenate through the lungs. So instead of passing through the ventricles and giving in the lungs, which you don't want to do while they're developing, you had a couple of shunts that were there. This is one of them. Sometimes it remains patent. You may be able to pass your probe through this fossa ovalis. If that flap is there and you can still get into the left atria from the right, then you have a probe patent fossa ovalis. This IVC valve is a good indicator to also help you find the opening for the coronary sinus. You can actually stick your probe in through that coronary sinus opening and see that your probe would enter the coronary sinus on the posterior wall of the heart. Now, if you look at the image in the bottom right, you can see that flow of blood I was describing. You can appreciate how the IVC would really help to shunt blood away from the right ventricle and towards the intraatrial septum. So as we move out of the right atrium, we pass into the right ventricle through the tricuspid valve. The tricuspid valve is seen here. It's almost similar to a parachute in a way. So the tiny cords here of the parachute are the chordae tendineae. As the valve is described as a tricuspid valve, it does have 3 cusps for its valves here. You have a septal, an anterior, and a posterior. And you have dedicated papillary muscles attached to those chordae tendineae. And therefore, the papillary muscles are named in a similar fashion to these tricuspid valve cusps: anterior, septal, and posterior. Now, the anterior one has an additional structure that needs to be identified that is going to contain a portion of the conduction system of the heart. This is the moderator band, and the moderator band is going to extend from the interventricular septum over to that anterior papillary muscle in the right ventricle. And it's going to carry a portion of the conduction system to allow for the correct coordinated contraction of these ventricles. So, in addition to papillary muscles, we have one other muscle we need to look at. So the papillary muscles are there in association with the chordae tendineae, the cusp, and then the anterior papillary with its moderator band. But embedded within the wall of the ventricle on both sides, we have trabeculae carneae muscles. These are fleshy, bean-like looking structures that make up the rugged wall of the internal aspect of the ventricles on both sides. So let's look at the atria. The left atria here has been cut open and then pulled open and almost retracted to show its internal linings here. You can see that all 4 pulmonary veins are still intact, but that is a variable number. Don't be disappointed if you do not find 4 vessels during your dissection. And really the only internal structure here you're going to see is a depression in the wall
from the fossa ovalis that's in the right atrium. Now, let's look a little closer at the ventricle. If you look in the bottom right picture, you see again we are making that U-turn as we pass the blood through the mitral valve, hit the apex there of the left ventricle, and then turn to shoot through the aorta. The aorta has been opened up here and the walls retracted back to reveal the 3 semilunar cusps here. And you can see they almost look like bowls. Each has a little nodule to help them meet up and make a full, almost like a Mercedes-Benz sign. But only 2 of them actually have ostia or openings for vessels. So here you see the posterior cusp, and here you see the right and the left cusp. The right and the left are known as coronary sinuses. Sinus because it's almost like a bowl. So the right cusp is a coronary sinus, while the posterior is a non-coronary sinus because it doesn't give off a coronary artery. So here you see the right coronary ostia, where the right sinus is going to have the ostia located in its lateral wall, and that's going to be the origin of the right coronary artery.
Here's an anterior view of the heart, and we're going to remove the atria so we can understand the valve organization more internally. So now we're at the base of the heart at a posterior view, looking through the oblique axis. There is the right atrium removed. There is the left atrium removed. So you can see the valves between each of the chambers, moving from atria to ventricle. On the right, our tricuspid. On the left, the mitral. You can even see the tendonae cordinae that is tethering those valves and preventing the cusp from prolapsing through the action of the papillary muscles of the ventricles. Now see, they're almost all in the same plane. Let's remove the aorta here, the ascending aorta, and the pulmonary trunk here. So the pulmonic valve is most anterior, and the aortic is just behind it. And just behind that are tricuspid and mitral valves.
So heart sounds or heart auscultation is not really lining up in your head probably when you look at this anatomy and then you go to do your physical exam or think of where heart sounds should be. And we see in the diagram here an A for the aortic heart sound, but we see it placed over the superior vena cava. And you have to think about the flow of blood to understand the heart sound locations on the chest wall. The flow of blood for the aortic is going to be that coming in from the left atrium and doing the U-turn that shoots out through the aorta. And it's the projection of sound through that valve and hitting that aortic wall to turn in the arch that's going to be megaphoned out. And so you want to be right past where it's coming through the valve and shooting the sound. So the aortic, it would make sense, would shoot this way. And if the pulmonic is seen here and you think about the flow of the right heart blood, you turning in the right ventricle and out the pulmonary trunk, you can understand why the sound would radiate to this area. So work through that on the other 2 valves and make sure you understand why the tricuspid and mitral valves are seen in these respective areas. So here's an anterior view of the thoracic cavity. You can see we removed the thoracic wall, we've removed some of the pericardium as well as some of the costal parietal pleura, And the Veit relationship in the superior mediastinum I want to introduce quickly to help you understand the great vessels just a little more. And you can see the brachiocephalic vein, aortic arch, and its associated branches here, 3 of them typically. The trachea would be just posterior, and then the esophagus, as you saw in that last image, is just posterior to it. And so this relationship, remember, is only in the superior mediastinum, above that transverse thoracic plane, between the mediastinal parietal pleura, and below the superior thoracic aperture. What else is here you need to watch out for during your dissection? Well, this nerve I hope you already know because we've introduced it a couple times. This is your phrenic nerve, seen with the pericardiacophrenic artery traveling between the pericardium and the mediastinal parietal pleura. The next arrow indicates the vagus nerve. Remember, we talked about the phrenic being anterior to the root of the lung, as you can see it here with the pulmonary artery. You can also appreciate that this is the vagus nerve then, because you can see it diving posterior to that. Now, as it goes on the lateral aspect of the aortic arch, before it dives behind the root of the lung, it gives off a tiny branch, then on the left will sweep under the aortic arch. On the right, the branch comes off a little higher, and it actually sweeps under the right subclavian artery. This is the recurrent laryngeal nerve. You can see it better in this next image. We've removed the heart and cut through the aortic arch. It's highlighted, it's circled in green, and you can follow the vagus down right where it's there with the common carotid coming down on the lateral aspect of the aortic arch. And the vagus continues to descend with the aorta, while the recurrent laryngeal.
Let's look at the great vessels. The aortic arch, you can see moving in a fashion where it's anterior to posterior, but it's also moving to the left just a tad. So let's stand behind that structure and see, if we move the spine out of the way, we can appreciate that the arch is to the left. It starts midline, and as it moves posterior, it goes just to the side of the vertebra. So the vertebra, we're here, and we're just off midline now as we become the descending aorta. And so that arch is at that transverse thoracic plane. So the start and the end of the arch are at TV4-5. The transition from ascending aorta to the aortic arch, and then the descending from aortic arch to descending thoracic aorta. A lot happens here. See that little yellow guy wrapping around the aortic arch? Any guesses who that is? Well, we know this is the phrenic nerve because it's packaged anterior to the root of the lung with the pericardiaco-phrenic artery and vein. And so if we look posterior, we can find vagus. So this is our vagus nerve coming out of the neck. But it's really, on the left, very intimate with the aortic arch. And that's because it's going to send a branch off that reoccurs, the recurrent laryngeal nerve here that goes all the way back to the larynx in our voice box. And so it scoops here under the arch and then goes up in the tracheoesophageal groove just medial to this common carotid here. How do you find that? Well, you're going to find it in your dissection using a ligament. See the pulmonary trunk? Just before it splits into pulmonary arteries? There's a ligament that connects this trunk to the arch of the aorta here. Ligamentum arteriosum. It was a shunt, the ductus arteriosus. When you're born, remember from our embryological discussions, that is going to close off if all goes as planned and allow us now to no longer bypass the lungs. And that ligament then becomes a structure that we can use to identify the recurrent coming off the vagus nerve right here over the arch. Now we don't have an aorta on the right. And so what we see on the right is that it hooks underneath the subclavian. And so you would have it coming off just here and reoccurring superiorly.
To review, we have hopefully developed a three-dimensional view of the heart, the middle mediastinum, and the associated structures. You can look at the heart and identify the different surface features, but also visualize the structures within the chambers internally and understand the blood flow through those chambers and the associated structures that are going to contribute to the flow.